Hello, my name is Jens Hillengass. I'm the Chief of Myeloma at Roswell Park Comprehensive Cancer Center in Buffalo, New York. I would like to talk about the abstract that I had the privilege to present at this year's ASH meeting 2023 with the title, The Phase 2 CARTITUDE-2 Trial, Updated Efficacy and Safety of Ciltacabtagene Autoleucel in patients with multiple myeloma and 1 to 3 prior lines of therapy, which was cohort A, and with early relapse after first-line treatment, cohort B. This study summarizes, or this presentation summarizes 2 cohorts of the study enrolling patients with earlier lines of therapy. As you might know, Ciltacabtagene has been approved for patients with later lines of therapy, 3 or more prior lines in Europe and 4 or more prior lines in the US. And these cohorts, A and B, enrolled 2 different patient groups, but they are both early stage or earlier course of disease. Therefore, we present it together. And the cohort A enrolled patients with 1 to 3 prior lines of therapy, and they had to have had a proteasome inhibitor and an IMiD. And cohort B was enrolling patients who had 1 prior line of therapy and relapsed within 12 months, either after autologous stem cell transplant or after the beginning of treatment if the patients were not transplanted. Earlier has been shown that the overall response rates were 95% and 100% respectively. What we show here is a follow-up after over 2 years and a median follow-up of 29 months. Here you can see the patient characteristics that were enrolled for the 2 cohorts. Cohort A enrolled 20 patients, cohort B 19, or at least 19 received the Ciltacabtagene treatment. There were some patients with extramedullary disease, which is reflective of this patient cohort. Some patients had high-risk disease, actually more so in cohort A than in cohort B, which shows cohort B is basically showing enrolling a group of patients who are biologically high-risk disease, even though they don't seem to show that at first diagnosis, meaning they had an early relapse after stem cell transplant, which kind of reveals that they have a more aggressive disease. The prior lines of therapy is, of course, a median of 2 in cohort A and a median of 1, because that was the definition of the inclusion criteria in cohort B. Here you can see the MRD negativity rate, the minimal residual disease negativity, was measured with a threshold of 10 to the minus 5 with next generation sequencing or next generation flow cytometry if the next generation sequencing did not work. And you can see for all the patients who were evaluable after 6 months and after 12 months, 72.7% and 76.9% after 6 months were still MRD negative, and 50 and 61.5% were still MRD negative after 12 months. The numbers look a little bit small, but that's because the bone marrow biopsies for assessment of MRD were done after 2, 6, 12, 18, 24 months, and then yearly thereafter, or when patients achieved complete remission. Therefore, not always kind of this sequence of 6 months or 12 months would be met in a patient, and they could not be evaluated for this question. Here you can see the overall response rate. As you can see, almost all patients responded, and most patients actually responded with a deep remission, meaning complete response or better. And you can see it didn't take long. Most patients responded within 1 month, and the time to best response was between 3 and 5 months. The duration of response rate after 24 months, because the median duration was not reached yet, we measured the rate of 24 months duration of response was 73 and 70% respectively. Here you can see the Kaplan-Meier curves for progression-free and overall survival. As I mentioned, both medians were not reached yet because patients did so well. And if you look here at 24-month landmark analysis, 75% were still without progression in cohort A, and 75% were also still alive in cohort A. For cohort B, looks very similar. The progression-free survival after 2 years was 73.3%, and the overall survival was 84.2%. You can see the side effects. They are not very surprising. Most of them were hematologic side effects, as expected with a treatment with CAR T-cell therapies. There were a few patients who has a second primary malignancy, but since it was fairly short after the treatment, it's not expected that this was related to the treatment itself. 3 patients passed away in each cohort from a progressive disease. In cohort A, 2 patients had an infection and passed away from that. And in cohort B, there was 1 patient who had a cardiac arrest. From the typical CAR T-cell toxicities, CRS and neurotoxicity was seen, but it was manageable, and not many patients were grade 3 or 4 CRS, and no patients had grade 3 or 4 ICANS, the immune cell-related neurotoxicities. There were only 2 patients who had, 1 patient who had this movement and neurological toxicities. All CRS and ICANS cases resolved. In summary, this shows a very good response rate in patients with not many prior lines of therapy. So in earlier treatments, 1 to 3 prior lines in cohort A with 100% showing MRD negativity with a 10 to the -5 threshold. After 24 months, still 75% had not progressed and were still alive. And for cohort B, 93% were MRD negative, 10 to the -5. And after 2 years, progression-free and overall survival rates were 73% and 84% respectively. It's worth mentioning that the cohort A patient definition was basically, or inclusion criteria, have also been used in the CARTITUDE-4 trial, which is a phase 3 trial and has already been published. I thank you for your attention, and of course, I also thank our patients and the sponsors of this trial, all the co-authors and the staff from our sites.